Yes, so I'm Disa and I'm the Assistant Director of Regulatory Affairs at the Independent Healthcare Providers Network.
So my name is David Hare. I'm the Chief Executive of the Independent Healthcare Providers Network, the organisation that represents the independent healthcare sector in the UK.
Yeah. Good afternoon, my name is Dr. Freeman. I'm the Clinical Director for the Independent Healthcare Providers Network.
Thank you.
Good afternoon, I'm Karen.
Sorry, I can't see your, there's too many bottles in there. Right, okay.
Good afternoon, I'm Karen Prins. I'm the Chief Executive Officer of BMI Healthcare.
Sorry, you're the Chief Executive of?
BMI Healthcare.
Oh, yes.
And I also have a clinical background.
Thank you very much.
I'm Stephen
Not
Luttrell.
a bottle in the way. Sorry, bottle. Now it's got the sweets in the way. All right. Thank you very much.
I'm Stephen Luttrell. I'm the Group Medical Director for BMI Healthcare.
Right.
Hello, good afternoon. My name is JJ Gorter. I'm Chief Medical Officer for Spire Healthcare,
Right.
and I'm responsible for medical standards, governance and oversight.
Right, thanks very much.
I'm Mahmood, Shafi. I'm a Medical Director and Responsible Officer for Nuffield Health. I'm still a practicing gynaecologist but specialising in oncology cancer work in Cambridge.
Right, thank you very much. That's very helpful. So, first of all, I ought to ask you, have you any questions of what I've just said? Has anybody got any concerns? No, right. So, if I could first of all ask the Independent Providers Healthcare Network, there are relative differences in the proportions of patients implanted with mesh between the NHS and the private sector. And I'm just wondering, could you explain to us a little bit about the differences?
In terms of the numbers or in terms of the sort of
Well,
processes?
both.
I mean, I think on the numbers, we don't have sort of precise numbers of exactly what was done within both sectors. I think one of the challenges that we're engaging with at the moment, doing a lot of work on, is to how we can ensure that there is greater alignment and consistency between both the independent sector and within the NHS. And I think there's, happy to get into the details around that. Part of it is around data. This is the importance of the submission of data, and we believe there is a real opportunity to have an improved alignment of data information available to the public across both the NHS and the independent sector. Clearly, indemnity is an issue that there is focus on at the moment, and where there's the opportunity for greater alignment as well, and within some of the areas of governance as well. So our view is that we need to be pushing harder to see whether or not we can bring those two things together, for the end user, for the patient. And I know you spent a lot of time talking to patient groups through this inquiry. Ultimately, they want a joined up seamless health service that is as safe and open and transparent as possible. I think a lot of strides have been made in recent years to improve that, but fundamentally we see there is more to be done to ensure that alignment between the NHS and the independent sector is done. Not saying one is better versus the other, and there may be some areas where difference is right, but generally speaking we need to be bringing those two things together a little bit more. I don't know how, if you want to think that.
Just to endorse that and to say that having been at IHPN, its predecessor, for about 3 years now, and coming into it with a lot of experience in the NHS in terms of being a medical director and governance, it was quite clear to me that there were differences which were both appropriate, and as much as you're not running NHS organisations, and I've never believed that everything that the NHS does is absolutely correct, but what was important was to get comparability so that we were clear that we could compare like with like. And that's really what we've been spending the last 3 years trying to do, to ensure that if we don't have identical systems, we have comparable systems. And you all know, Julia, that the independent sector previously was regulated in a totally different way to the NHS in terms of the regulator, CQC. It has moved to regulate both in the same way, and part of it has been to ensure that has been comparable in sectors which operate very differently and see effectively different ranges of things. So there isn't the acute work, in terms of the emergency acute work in the independent sector, that the NHS has. But there is still a very significant amount of acute surgical work, and it's about 10% in some specialties are done in the independent sector for the NHS.
So if you take an individual patient who actually goes to both parts, so it goes privately, goes to the NHS, back privately, back to the NHS, how does the data then inform you of what's happening?
So I mean, I think I should make clear that IHPN as a membership organisation, we don't necessarily have lots of data fed to us by individual providers about patients. That would go into the regulatory system. I think a general point, of course, across the NHS and the private sector is you're often talking about the same clinicians. We'll work across both sectors, and that is common. There is a small cadre of consultants and clinicians that will just do private work, but most will work across both. Both provider types will submit information, whether it be adverse events information to CQC, as Howard described. I think the regulator will assess organisations based on, are they well-led, responsive, caring, healthcare providers. It doesn't necessarily look at the payor type. So in terms of the regulatory requirements across both for the CQC, they are, they're exactly the same. I think what Howard was describing was, I think, a push that we've made, supported by others as well, to say, well, okay, where there are NHS-specific systems, and the National Reporting and Learning System would be one of those, and that's now migrating across to DP SIMS. We've been looking at the sort of health, the health safety, yes, the health safety sort of investigation board, making sure that too can investigate major incidents were they to occur in the private sector. So a part of what we're having to do is push quite hard to ensure that we can align to those systems where they're right. But actually there is quite a lot of alignment across both systems, particularly from a regulatory context.
I just wonder, I think both sections have an important part to play in the health of this nation. But I'm just wondering, if things go wrong in the private sector, what action is taken? How is that resolved?
Clearly, fundamental responsibility for what happens within any provider organisation, it's the same in the NHS and the independent sector, is it's for that provider to ensure that it puts right any identified issues or challenges. Clearly, there is also the reassurance to patients around the CQC inspection regime, where the CQC will identify problems and issues and ask providers to tackle that. So first and foremost and fundamentally, it should be for the provider organisation to deal with issues and deal with concerns that get raised.
Yes, and not only is the regulator of the provider the same, but of course the regulator of the professionals involved is the same, and the standards that the regulator of the professionals applies is identical. It doesn't matter where you work. The General Medical Council, Nursing Midwifery Council will apply its code to you. So there is that level as well. One of the things that we need to reflect on is that the independent sector, the people that we represent, most of them do both work for the NHS, which is regulated by the NHS, and they do work which is paid for by the individual or by insurance. So there are differences between the patients and the way that's regulated. And my colleagues may wish to pick up on that because they have to operate that on a daily basis.
We would, in terms of complaints, have a system that's aligned with the NHS system, and the incident system would be the same. So if things go wrong from an adverse event perspective, we have a system of escalation and recording those. Similarly, a complaint system which has an escalation to an independent review if necessary. And those are regulated to the same standards as the NHS would be regulated through CQC and the GMC system. We're keen to contribute to single systems that would give a better overview across the whole, because sometimes it's only possible to spot a trend or an adverse trend early on, if you can see the system as a whole, and I think with my colleagues we share a desire to contribute to single systems that would enable adverse event trends to be picked up and spotted more quickly than they perhaps have been in the past.
So do you, as private organisations, you have a responsibility to put things right when they go wrong? If you have an operation, insertion of mesh that is causing a lot of problems, that is then recognised and then you try and put that right?
We would do.
And then if the individual is actually paying for that, and we've heard quite a lot of stories from women whose parents, the banks and mum and dad, have actually supported, especially when things have gone wrong, because the initial operation was affordable, but then they actually have a problem in terms of putting it right. So who pays for that second event where you're trying to put it right?
We would discuss that with the patient on an individual case basis. There is, for many operations, a recognised complication rate, but in some circumstances that complication rate may be over and above what would be regarded as usual or normal, or related to perhaps something that's gone wrong in the operation or something that's gone wrong with the device, and in those circumstances we would look to work with the individual concerned to rectify that.
Could I just add to that? So I think there's two duties. There's a statutory duty, but there's also the moral duty. So the statutory duty around duty of candour, we all comply with and we follow. I think in terms of moral duty, it's the duty to do the right thing. So in the example that you've given, we consider it our duty to put the patient right. We've done that for metal on metal, where we had to communicate with 4,500 patients. We did it with the PIP breast implant scandal. I think the financial issues are at the very back end of it. The first thing is to do the right thing by the patient and to ensure that further harm isn't occurring. And then we'll consider all the other duties afterwards, which for us are secondary. Because the first is, what's our duty to the well-being of the patient who's trusted us?
And as far as Nuffield Health are concerned, we have what's called the Nuffield Promise, so that we promise to put right any issues that arise from any surgery where the patient is paying for that surgery. So if there are unforeseen complications as a result of that surgery, that is put right at the cost of the provider, i.e. us, rather than the patient. So it's no additional charges whatsoever for the patient.
So can I go a bit further, because I'm thinking about mesh now, the insertion of mesh. If the patient is really very anxious to have the mesh removed, do you provide that service, or do they have to go to somebody else?
So with mesh removal, it is a very specialised service.
Yeah.
I think one of the important things is to get the diagnosis right. So
Sorry, the important
the
thing is...
diagnosis right, because all actions follow on from a correct diagnosis. Not everybody presenting with an issue post-procedure will that be related to the actual surgery. It may be something else. So I think it's really important to clarify what is causing the patient's symptoms. And there are accredited centres up and down the country. The mesh, as the committee will know, is designed to be inserted and for it to be incorporated into the body, so it is embedded within the tissue. And to remove that is a complex procedure, and we need expertise from gynecologists, from urology surgeons, from bowel surgeons, from people who specialise in imaging for that particular area, and also people with pain expertise, to try and clarify what the cause of the patient's symptoms are and what the correct course of action is. And that is primarily within the NHS, because that is where the volume of activity occurs.
I do understand all that, but I'm just sort of wondering that, and I don't know, and you will tell me because you're providing the service, how much if you are equipped to do removals or do you pass it on to somebody else, or how do you manage that?
In large part, it's a clinical decision, so we're reliant on a specialist to advise whether our facility is the appropriate one for the patient to have removal surgery. In many cases it isn't, because it's complex surgery, but ultimately we're having a three-way discussion between ourselves, the clinician and the patient, to determine where's the best place for their care to be delivered. And that's an individual discussion. It's difficult to make generalizations. If we're able to do it at our facility safely and effectively, then of course we'd like the patient to return to us and for us to have the opportunity to put things right. Sometimes that isn't possible. Sometimes patients, their best outcome is to be achieved in a tertiary centre, which is usually a NHS centre. In which case what we'll do is we'll look to facilitate their care and the transfer of care to somebody at that centre. And we've done that a number of times.
And who funds their care?
So if they were self-funded and they still wish to be a self-funded patient, we would take responsibility for that. If they were an insured patient, then maybe it might be covered by insurance, but ultimately we're not going to allow a delay to take place while that's decided. So we'll try to negotiate. First of all, we try to identify the best place for them for their care to take place. If it's clear that the responsibility and onus is on us to fund the care, we agree that quickly. If it's less clear, if it's a question of arriving at funding as quickly as possible to allow care to take place, we'll just arrange that and reclaim at a later date. Our goal is not to delay care and to continue any undue suffering or harm.
And that's a decision for the multidisciplinary team to make and advise.
Sorry?
It's a decision for the multidisciplinary team to
Yes.
make and advise a patient as to what the next appropriate steps are.
Yes, right, okay.
Well, before I start, I must declare a conflict of interest because I'm a non-executive director of the Private Health Information Network, and as in fact is David. Right. I am aware how much closer the NHS and the private sector is working nowadays, and in fact the creation of FIN, the Private Health Information Network, is part of that. And David mentioned the need for having a database which is comes together, and you mentioned that a large proportion, 45% I think it is, of the activity in the private sector is on NHS patients, so they come together. It has been suggested to us that in the private sector, the institutions are less concerned about the governance around clinical care than the individual. That in the NHS, the NHS elects to look after the patient, whereas in the private sector, the customer is also the doctor as well as the patient. And you've already said this afternoon that you take your responsibility of caring for patients as institutions just as seriously. I accept that. So with that as the background, can we just discuss for a moment the revalidation procedures of the General Medical Council and the position of the responsible officer? Because again, it has been suggested to us that maybe in certain parts of the private sector, less so I think in the big institutions, that the responsible officer is not as close to the management and to the GMC as they are in the NHS. So would one of you just like to, maybe you have, tackle that one?
Well, it might be better, Cyril, if one of the responsible officers here actually answers that as it really is. I don't know if you want to answer that, JJ?
So I'm happy to pick. I used to be a responsible officer, I'm not now, but the responsible officer reports to me.
Yes.
I think quite the converse is true. So I've been on the board of a NHS trust, and I've chaired its quality and safety committee for a number of years. So we have, I'd say that the process in place that we have in place to discharge our accountability in relation to the R regulations are very strong. And indeed, we had NHS England who came and visited and did the high level RO visit only just in October, and they made no recommendations as a result. We have 330 consultants and doctors who connect to us for the purpose of revalidation. I think our approach is extremely rigorous. On the other hand, the information we sometimes receive from NHS trusts, and we must engage with over 200 NHS trusts across the country, some is very good and has definitely improved, but the outputs are variable. That's the truth. And variable in terms of willingness to share information openly, share information proactively, and in terms of the quality outputs of appraisal that we receive. And if we're unhappy with them, we're quite clear, we return those to the individual and we put their practicing privileges on suspension until we're happy with it. Now that's taken some time to get to that position, and it's created some friction, not only with consultants, who aren't our customers, by the way, they're our partners. Our patients are our customers, and that's quite clear for us. So our consultants as partners, well, we've upped the bar, we've made clear our requirements for them to work in partnership with us to put patients' interests first and foremost. But we're there now, and I'd say our systems are very rigorous. I can't speak for everybody, but the medical directors and the ROs from across the independent sector, we communicate very effectively because we're a relatively small group and most of us are headquartered in London, so we come under the same NHS England region, which helps in terms of communications and forward communications and soft intelligence especially, because it's not all about the numbers. But my view from what I've seen is that the independent providers who discharge their responsibilities under the RO regulations do so very seriously and very rigorously.
So I'll come in on that if I may, Cyril, because I deliberately let JJ answer it first. I was an RO, of course, in the NHS, and I still do appraisals in the independent sector. My view, having spoken to the ROs in the independent sector, is the rigour is exactly as JJ says. The numbers are smaller. It's often easier for them to do in terms of being rigorous. The constant issue that has come back to me, and I've taken it up both with the former medical director at NHS Improvement and the current national medical director at NHS England, is the inability, in many cases, not in all cases, but in many cases, for the independent sector RO to get information from a consultant's NHS RO. And I've got email after email. It's often that they're just ignored, the emails are not answered. So there's a real issue, and sort of a real takeaway from me is there's a real issue about the dialogue between the NHS and the independent sector ROs when the independent sector RO asks for information. Now, I'm not saying that everyone in the independent sector is perfect. No, that doesn't happen. But there is clearly an issue, and it's been going on now for as long as I've been clinical director at IHPN. And as I say, it is something I have taken up on several occasions with the senior leaders of the NHS.
Thank you, that's very helpful. Can I also then ask a question which is related to the same thing about coordination between the NHS and the private sector? When we recommended a pause in the insertion mesh last summer, and NHS England effected that, what of course was clear from NHS England is that they had no jurisdiction over the private sector. So we had some concerns about whether or not the private sector would themselves follow the advice that we had given. Can you just explain to us how you reacted to that, JJ?
So that was the safety alert that came through, and I think all of us in the independent sector took immediate action. So there was the exact same pause that was recommended right across the board, and since then, as far as I'm aware, no such procedures have been undertaken within our organisation since then. And in fact, we have reassured NHS England that that is the situation, because it is in all of our interests to be able to do that. We're far more stringent than needs to be in this situation. Patient safety has to come foremost with all of us.
I mean, at that time there was no immediate collaboration between the medical directors about the implementation of the alert, and we all implemented it in line with NHS England's expectations. We implemented it in Scotland as well, the same recommendations using the same system. And I know that I've, in line with the guidance, authorised 2 operations since that time through the high vigilance system.
Thank you.
Can I ask then what you're doing for women who come to you suffering very much from incontinence? How are you coping with their troubles?
Those would be managed by individual consultants within their clinical competence and using their skills. I know that they have been supported by their associations in terms of the explaining the options that are available to women when the mesh is not a desirable option now.
If I may. So we complied with the mesh, and then we shared the approach with NHS England, and we had a conference call with them. Women on high vigilance procedures can still have those, but what we require is evidence of the MDT prior to the procedure being booked. We need evidence from the consultant's responsible officer that this forms part scope of their NHS practice, and that they're deemed capable and competent to undertake the procedure. We ensure the patients have all the information to support informed consent as to the risks and benefits and alternatives of the procedure they're having, and then we require the individual consultant to enter the data onto the relevant registry. So those are the 5 requirements. Now, we've had a handful of those since the pause came into effect at the beginning of July, but we audit that and we monitor it, and the consultants who've undertaken this procedure have complied with all the guidance from the pause and in relation to the high vigilance procedures.
It would be very helpful to us if we could have those figures. Is that possible?
This year we've had 6 patients
Right.
undertake a high vigilance procedure in line with the guides from NHS England and NHS Improvement.
Have those been self-funded, or are they NHS referred?
I can't tell you, I'm afraid. I can tell you, but I haven't got that information to hand.
But
I'm happy to provide that afterwards, though.
6 from your organisation. How about 2?
None as far as I'm aware.
No.
Chair, happy to coordinate that
Yes,
a
that
bit more
would be
broadly
very
if that would be
helpful.
useful,
Yeah,
and
thank you.
let you know.
I think the thing is with surgery, it has to be that you have to look at all the options available. Surgery is not the only option available. I think with the introduction of these techniques, it quite often became a much earlier option in their pathway than would traditionally have been the case. So there's things like physiotherapy, weight loss, and other medical inputs that can help these patients with these symptoms. So yes, surgery should still be an option. I think it's about training, it's about audit of their practice, and it is also about consent, proper consent, informing them of all the options available, all the pros and the cons associated with each of those decisions, and allowing the patient to choose what they see is the most appropriate for them.
But it isn't just the mesh procedures that fall into the high vigilance by exception, of course.
Correct.
It is the others, so be interested to know the numbers of the others that you're doing under high vigilance. But also the point that you were making, if one of the conditions is about assessing the competency of the clinicians who are undertaking these, I think your point was that you're not getting the information you want from the NHS when you're asking for it. So how are you able to satisfy yourself as to medical competency?
So we only approve a consultant once we receive the information. If the information isn't forthcoming, they're not entitled to undertake those procedures in our hospitals.
And
it's
that's
up to
true
them
across the piece.
to make the information available, but we require it from the responsible officer. It's not on a slip of paper.
But do you monitor individual surgeons' performance within your own business? I mean, do you know once you've got that surgeon practicing privilege, how effective he or she is at what they're doing?
So we track their practicing privileges, well, first of all through appraisal. So we provide them with a standard data set that's made available for the appraiser to consider their scope of practice with us as part of their overall scope of practice. But we also undertake a biannual review of their practicing privileges that looks at complaints, incidents, claims, soft intelligence, volume of practice, type of practice. And that's a formal process that gets considered by the registered manager but signed off by the medical advisory committee. So that's a formal process.
Is that similar across all three providers?
Yeah, pretty much.
So if that's a robust system, we shouldn't have expected to see mesh operations being conducted in the private sector that resulted in poor outcomes due to the quality of the surgical intervention.
Well, I think one of the issues was that it's not that clear. It's not that clear that once a mesh started being used, there were poor outcomes. So in terms of complaints, there wasn't a trend of complaints suggestive that mesh resulted in poor outcomes. The rates of readmission for an individual didn't look untoward to the point that you would want to intervene or start asking further questions. And we have quite inquiring minds. So our first response to an incident of complaint isn't, this is a rare thing, it's only happened once or twice. Ours is, first instinct is there a broader issue here, and we need to investigate until we've ruled that out. So we do have inquiring minds. We don't take an issue, an incident, even if it's isolated, purely at face value. I think that's part of the cut.
Is the system geared to look for long latency issues?
So but I don't think that the system captures implanted devices of any sort looking for longer term or longitudinal failures. There's a question about the regulation of medical devices, whether that's adequate or strong enough. There's a question there. But on the assumption that it is and it gets approved, my view is that any implanted device that isn't absorbed ought to be entered onto a registry, because quite often the adverse outcomes which are unforeseen, because they're unforeseen because otherwise they would have been approved, don't become apparent until much later in time. Something like the National Joint Registry works really well, and that has helped in the recall or suspension of specific devices because the longer term consequences weren't apparent or foreseeable at the outset. I think that any implanted device ought to be subject to the same principles.
But there are two issues, aren't there? There's the device itself and its short and long term efficacy and safety inside the human body, and then there's the implanting procedure and how well that was conducted. So are you confident on both fronts that you as an organisation knew enough about what was being done at the time?
So with devices, with surgical procedures, the majority of consultants working in the independent sector will have an NHS contract. Their appraisal will be within the NHS. They will have whole practice appraisal, i.e. the data from the independent sector. Whichever organisations they work with will feed into that appraisal process. I think it's two issues that are important. It's not just about the quality of the surgery that's undertaken. All surgery has a complication rate, and simply the alternatives to these devices also have complications rates and significant complication rates. In fact, a lot of the surgeons have now become de-skilled in doing these procedures because they have been brought up with these newer devices. The other issue is with regards to the mesh types as well. So it's not just mesh per se, it is the different types of mesh and how they react within the body and the evidence that supports that as well. And I think there are major issues in the multiplication of the different mesh types and the mesh procedures that came on stream through the industry and that's led to some of these issues.
NHS Digital was able to do a 10-year retrospective audit of mesh procedures for stress urinary incontinence and prolapse. Could the private sector do the same?
In terms of identifying all the patients?
Retrospective audit. Yeah. Well, first of all, just looking at the numbers and the complications, and because one of the issues that when that data came out was, we've got no information on the private sector, so we can't look at the thing in the totality. So first my question is, could the private sector do a 10-year similar retrospective audit? Do you have the data necessary? And the second point is that if there had been a safety alert, a recall, would you be able to find the women, find the mesh, do anything about it?
And can I answer a a link question around that as well, which is I think it would, in the event of NHS Digital or any other national body requiring information from healthcare providers, actually it is critical that they come to all providers, including the private sector. So I think, you know,
it wasn't done for that retrospective
yes.
audit, and I'm just asking, could you actually do it? Do you have the data?
We could
back 10
identify all
years.
patients who received the mesh, yes.
You could do a 10-year retrospective audit of the numbers of procedures that were undertaken and where they came back for problems or complications throughout patients. You could do that.
So that's more complicated, given enough time. So we could identify patients with who've had a mesh, and what we have to do is go back through our adverse event and complaints processes to try to correlate if any of those went through a complaint, ended up in a complaint or an adverse incident. The complicating factor is they may not have returned to us if there's a complication.
Sure.
So we would only know those people who come through to us. We've been working very closely with Finn and also with the ADAPT program to try to have a common patient identifier so we can track patients across systems. Somebody mentioned that.
JJ, can you just explain the ADAPT program, because the video.
Okay,
Yeah.
I'll do my best. I'm not an expert,
David,
but perhaps David.
Yeah, happy just to fill on that. So the Acute Data Alignment Programme is an initiative led by Finn, which is also Clarence, I'm a director of that organisation, is an attempt to try and identify what are the data feeds and bits of information that can be consistently applied that are currently held by the private healthcare information network and potentially held by NHS Digital. So there is consistency across both, and one of the benefits of that, as I think JJ is describing, is much greater transparency around patients that move between private sector and the NHS, so you can see more across the whole of that system. And as I said at the outset, the ADAPT programme is something we very much support, and we think will have, you know, considerable benefit around transparency of information and data.
Okay. Just following up on your question, so we've got written guidance and a process for undertaking a patient recall, which starts off with identifying all the patients who might be affected. So we would be able to identify people who've had mesh, as we've done, people who've had metal hip systems or PIP breast implants or any implanted devices that requires a large scale recall. The more challenging bit would be reconciling those with who had a reported incident or a complaint or a claim, for example.
Well, I think in terms of partnership working, our preferred approach would be to work more closely with NHS Digital or any data repository. For a number of reasons, patients move back and forward from one bit of the system to another. So if I just looked down a BMI lens, I wouldn't capture necessarily the totality of patients' journeys. And secondly, to detect adverse events at an earlier stage, we'd be much better served in that aim if we aggregate the data across the whole. If each organisation just looks at its own silo of data, it would take us a long time to get the scale of data that would require us to come to a conclusion on adverse events. If we looked across the private sector with my colleagues and said, well, we'll aggregate the private sector data, we would be faster at spotting adverse events, but we still wouldn't be as fast as if we aggregated our data across the whole of the NHS and the private sector. That would give us the ability to spot adverse events at an earlier stage. And I think it's fair to say at the present time that the registry system, which is a tool for collecting data that enables adverse event spotting, is fragmented and not joined up and not necessarily easy to work with.
We support a unified system of data collection right across the piece. I think the same rules should apply. Currently, barriers exist to sharing information, sharing data, and I think those barriers should be removed. The other thing with regards to these particular procedures, as far as I'm aware, most of the surgeons, if not all of the surgeons, were actually entering data on their own databases as well, and that the society regulations, it was on a voluntary basis as far as I know, with the British Society of Urogynecology Disa database, but a lot of individuals were inputting that data.
And quite a few weren't as well. It was voluntary, and it certainly doesn't have complete coverage.
And that's not necessarily joined up with any systems that we have, so both that and things like the yellow card system, I can't tell if a consultant has put in an adverse event through the yellow card system. I wouldn't be aware of that, or into one of their professional databases. I wouldn't be aware of that one either. So
we're thinking about all those issues. I think the line of question is very much to assure ourselves that it's going to be possible to have common systems between the NHS and the private sector, so to the benefit of patients.
Absolutely. I think that would be a really valuable.
Can I just ask you, because we've got the big players here, if I can put it like that, and I'm just wondering, David, thinking about smaller players as well, how comprehensive is your network? Do you know what's going on with other organisations that perhaps are only doing 1 or 2 or 3, 4 operations a year?
So I think that, as I said at the start, we're not a regulator or a standards body, so the extent to which we can intervene is limited. What I think we are able to see is the range of organisations, from the single site all the way up to the groups. What we have been doing a lot of in the last year, 18 months, and following on from the Care Quality Commission report into the independent acute sector. I think one of the things that concluded was there is some outstanding care in the independent sector. I think the only 2 hospitals rated outstanding across all domains are in the independent sector in England, but there was a consistency challenge. Now that wasn't all about big versus small, but there was a consistency challenge in governance, and we absolutely acknowledge we can play a part in helping to support that. So one of the things that we're working on at the moment is we're calling a sort of consultant oversight framework, being led by the former NHS England Medical Director Sir Bruce Keogh, which will identify excellence, good practice, working with colleagues in here today and also outside, who have got systems and processes on safety. We don't compete on safety; it's a fundamental principle. And to help and spread that learning, we're running a number of learning events with the CQC, which involves the sector. So what we're trying to get at is, clearly, fundamentally, at the end of the day, the responsibility sits with the provider, but there are things we as IHPN can do to try and improve the overall standards, share learning from providers, and ensure that actually everybody is given every possible opportunity to ensure that sort of standard around safety is good or outstanding.
Yes, I think attendance at those workshops has been revealing, because it's been across the board. It's been, as you say, the big hitters, but also the people that just have one unit. So there's been engagement across the whole of the size in the sector. I don't think the issue of safety is something which even the small people want to be left behind on those blue.
But I certainly wouldn't want to give the impression that we are in any way blasé about that. I think the report last April from the CQC was clear. Some excellence and really good work, but some areas for improvement across the sector in terms of consistency. And we need to move forward with that. We are moving forward with that and taking forward projects and programmes that give, as I say, the best opportunity for those organisations that may be a little bit behind to catch up with the rest and to deliver the sort of safety services that you've been hearing about.
Yeah, but also just to say, it is possible for a single site provider to be outstanding in CQC safety. So it's not just that single sites are less in any way. You do have examples of outstanding single sites. And in terms of preparation for this review, we certainly surveyed our members to see what their responses were, and that included a lot of single site providers. We would say the same.
Thank you.
Could I turn to potential conflicts of interest? A number of people up and down the country have expressed anxiety that the rapidity of the uptake of mesh in treatment was, the enthusiasm was in some way stimulated by manufacturers working with individual surgeons and persuading them that this was the right way forward. We have asked the question to other organisations as to, should it not be the case that there's a register of interests by clinicians. I know the General Medical Council consulted on that, I think, in 2016, didn't at that time propose to support themselves doing it, but were interested in another body doing it. What is your view about the notion, like parliamentarians, that clinicians ought to have a register of interests for the purpose of transparency and openness?
So I'm wholly in support. If a consultant or any doctor has an interest in us as a listed company, we require them to put it on the website, and we list that for them. I think if a clinician has a financial interest in any medical device organisation, direct interest in a medical device organisation for which they're receiving financial benefit or support, I think it should be a requirement to list that. The difficult bit is if you invest in funds or pension funds that then subsequently invest in medical device organisations, it can be tricky. But I think if an individual is receiving support for research or travel, education, or a direct financial return in return for using a product or advising in relation to a product, I think that should be listed somewhere where patients can see it, where providers can see it, where regulators can see it.
You currently do that?
No, that doesn't exist in the UK.
No, within your organisation?
No, because we don't know who has financial interest in any medical device, because that doesn't exist nationally. But we would be very supportive. We don't. So if a consultant were to say that I have investment, this is my product and I want to use it, then we want that. We would want that association to be made public. We consider it when we're undertaking our health technology assessment, which is undertaken separately to the consultant. So if somebody comes with a new product, whether it's a supplier or consultant, we have a two-step process. One is to undertake an independent review of the health technology, and we go to external sources like the FDA, published research, NICE, etc., and we reach a view as to the efficaciousness of the medical device. But then we also then consider the clinician's competence to use that device, and then the medical advisory committee, as a third step, decide whether we're the right environment for the clinician to be using that device, which the answer may be no, even though the device is a competent device and the clinician is a competent clinician.
But once the device has marketing authorization,
yes,
then that doesn't apply, presumably.
No, if the device is new to us, we always undertake an independent health technology assessment.
Right.
The fact that CE marked is by itself would not pass the hurdle.
But you all, I saw you nodding, you all approve of what JJ said.
To be absolutely clear from an IHPN perspective, we fully endorse that. We believe that would be the right.
Now, when we put this to other people and organisations, we've said, well, yes, we think it's a good idea, but it would be nice for somebody to do it. There is the question of whether the General Medical Council might do it as part of the register, and we're discussing that. But the other people said, well, the organisation ought to do it. You know, the hospital, the NHS Hospital Trust ought to do it, or the private hospitals should maintain such a register. What's your view of that?
So we do try and do that. So certainly on our website, if you log on and you go to the individual surgeon, you will get a statement with regards to their interests or conflicts of interest. And similarly, as far as I'm aware, within the NHS, there is a register within the trust that individuals should list any funding or any interest that they have had from industry. That exists.
Can I just ask, is that a conflict of interest or is that just interests? You see, in the parliamentary system, we have to put our own interests and we have to update it every month, and it is scrutinised once a year, and it is then released to the public.
Yeah.
So people know exactly what we're up to.
It is interest that we try and capture.
Sorry?
It is interest that we try and capture. For example,
right.
if you go
so it's not a conflict of interest.
If you go on to my name, there will be several interests that are indicated on my website profile for my organisation.
Prior to today, I had a look at some of the organisations who are members who are not here today, and all of them, when I looked at the consultants, had that. The consultants had put something on. Now, the issue is, of course, one can't be certain that is everything. One can't be certain how it's outdated. And coming back to your point, Cyril, at the end of the day, it needs to be regulated by the regulator. So there needs to be governance over that. And in the NHS, broadly, there would be governance through the organisation, but for the individual, I think there does need to be GMC oversight and GMC governance of that. Otherwise, it's got no teeth.
I mean, the GMC has guided to this
Yes.
in 2013. I think it's about creating a single view of the truth,
Yeah.
and having a single source that people can be confident in. It's being updated regularly, that multiple providers or interested parties, including patients, can access. So I think it's about the how. I think the principles agreed. I think it's the execution that's inadequate.
Right. Anybody else? Any other question?
Can I just ask one question about the practicing privileges? Is there a sort of understood standard that you wouldn't have a surgeon, a consultant operating out of one of your hospitals if they were not going to be operating there or working out of there for at least so many periods in a year? I mean, is there some minimum? Because we understand that there are some that have a very large body of consultants sort of attached by way of practicing privileges, but actually may only turn up quite infrequently. So I just don't know whether there's an accepted standard that operates across the private sector about this.
So again, perhaps colleagues would like to
Yeah, so we've been looking at that. I have concerns about standards who are doing very small quantities of work, both in terms of their competence in that field of work, but also their engagement with the organisation and the teams and the policies in place that ensure safe care. So it is an area that we're looking at. I don't think I can easily draw a single line that applies to all consultants, because it may be appropriate to have a highly specialist consultant supporting another team for specialist interventions who may not engage with the hospital very frequently, but their input in certain circumstances is essential to make the whole work. Whereas for other consultants, it may be clearer that our expectation is a minimum input to the organisation per year, or evidence of minimum attainment of numbers of interventions that they undertake across their whole practice.
But as you say, there is the issue about working within that particular provider hospital, for example, and having familiarity with the procedures and policies there.
It is a process we're working through, is to define when that minimum has been reached.
I mean, is that sufficiently looked at by the CQC?
That is sufficiently looked at the annual PP approval input. Attendance volume are looked at, and just because somebody's high volume does not make them
No, it's not about their competency. It's just this particular aspect of being sort of familiar. It's a safety issue about being able to operate out of that hospital, to know the teams, to know the policies.
Absolutely. I haven't heard the CQC specifically asking a lot of questions about this area, but it's an area that we're specifically asking a lot of questions of.
But also, it is, of course, not just an independent sector issue. It is, of course, also an NHS issue, because when I was on an MAC, we frequently agreed honorary consulting contracts for consultants from elsewhere who would come in perhaps just once to assist in a procedure and come back several years later. I'm aware of no oversight that ever occurred of that, and I was never aware of a single honorary consulting contract having been given, being reviewed and taken away unless something catastrophic happened. So I think it is an issue for healthcare generally, not just for the independent sector.
Just one other thing for me. One of the many concerns that patients have raised with us is not just about the outcome of their treatment, but about the way they were dealt with by the consultants they saw. And women have talked about dismissiveness, denial, and an arrogant attitude that they've encountered every time they've tried to raise concerns about their treatment or even just questions about their treatment. And that applies in the NHS, their experience in the NHS, not just in the private sector. But I was wondering what what knowledge you've got of such experiences, whether that sounds surprising to you or whether you're familiar with such concerns, and what you're able to do about it as providers.
I have heard patients complaining about the attitudes of their doctors. We recently revamped our practicing privileges policy to make professional behaviour a much more explicit part of our practicing privileges agreements with consultants. So we take that, and I take the attitude and the professional behaviour of doctors very seriously, and have a number of supportive conversations underway at any one time with the executive directors who are looking at patient complaints about attitudes of doctors. So yes, I think it's terribly important.
So you recognise it as an issue, as a problem?
In recognising that it's an issue, in managing the issue with the consultant, ensuring that the patient is heard in terms of the complaint that they have, and that complaint is addressed with the individual consultant.
Yeah, there's variation. When we have 7,500 surgeons or consultants practice with us. Some are excellent, many are very excellent. There are the occasional few who I don't think engage in the way that they ought to. I take responsibility for that. So we as an organisation, we take responsibility for that. So if a patient complains, then it's our duty to follow up on their complaint, involve a consultant, meet with the patient, understand the exact nature of their complaint before we respond. And we take responsibility for that, even though it may relate to the consultant's attitude. If it's a persistent issue, we'll follow that formally with the consultant. If it perseveres, we'll suspend practicing privileges. If it's a probity issue, we investigate that formally, take it to a professional review committee, and if needs be, we refer them to the GMC. So we have to refer 4 or 5 people every year to the GMC. Some of it is for probity or behavioural issues, either towards patients or to colleagues. But we take responsibility for that. We don't just consider that that's a consultant's issue. They're our partners. They're not our customers. Our patients are customer. So it's incumbent on us to do our best and do the right thing by patients. Sometimes the issues are us, so we make mistakes. Sometimes the issues the consultants. Sometimes they make mistakes, but it's our responsibility to try to rectify that for the patient.
And they are covered by good medical practice guidance from the GMC, and we would hope that they defer to that as a model way of behaving when they are faced with patients and faced with issues. So that's a given as far as we're concerned.
Of course, your reputation is everything, as
Correct.
it is actually with other hospitals. But certainly, if you're in a competitive environment, your reputation is very, very important. No. Right. Any other questions? Sarah? No. Right. Have you any questions of us?
No.
I think we should congratulate ourselves. We haven't talked about Brexit today, thank goodness. I do want to thank you so much for coming. Thank you very, very much indeed. It's been a really useful session, and we're very grateful to you and for the work that you do. Thank you very much.
Thank you.
Thank you.